Hypercoagulable states. So clotting disorders characterized by too much clotting. So typically there's going to be venous thrombi, deep vein thrombosis, and pulmonary embolism. Less common, but still very common, is arterial thrombi, which will just be something like a stroke or a heart attack, where an embolus is going to clog up a coronary artery. Virchow's triad is talking about three conditions which can all sort of work together to cause excess coagulation. So number one would be endothelial damage. Number two would be stasis of blood. And three would just be hypercoagulable states where the clotting factors and the platelets are just basically overeager. So endothelial damage, let's think about this. When the red blood cells and the endothelial cells basically die, a lot of their membrane is going to spill out. And remember that phospholipase C is going to break up a lot of those phospholipids, generate arachidonic acid, which the platelets through cyclooxygenase can convert into thromboxane, which can help activate GP2 and 3 on platelets, which causes their aggregation. Similarly, ADP is released from red blood cells. This can bind to the P2Y receptor, which is going to decrease CAMP level, which causes secretion of platelets. Then thrombomodulin is necessary to activate protein C into active protein C. This is only generated by healthy endothelial cells. So APC's job is to prevent clotting, but if you have damage, then that means you don't have this, which means you might have clotting. TPA is going to activate plasmin to break down clots, but this is only active in healthy endothelial cells. If the endothelial cells are damaged, you don't have this, which means plasmin is not activated, which means clotting can develop. Heparin sulfate we've seen is only expressed on healthy endothelial cells. This activates antithrombin 3. Similar effect to APC, this is going to inhibit clotting. But if the endothelial cells are damaged, we don't have this, which means we will have clotting. And lastly, we degranulate von Willebrand factor, both from the alpha granules in the platelets, but also in the Weibel-Palade bodies in the endothelial cells. Remember that von Willebrand factor can release factor VIII, causing coagulation. It also can bind onto GP1 of platelets, causing adhesion. It can also, in a pinch, it's usually fibrinogen, but sometimes von Willebrand factor can be the intermediary between GP2 and GP3 of two platelets. So both adhesion and aggregation. So adhesion to subendothelial collagen, but also aggregation between platelets. The stasis is just if you have your blood is flying through like crazy fast through your circulatory system, but if you've been sitting for a long time or other reasons that you might be static, the slower velocity of the blood means that the factors can kind of pool, and a higher likelihood that they might bump into each other and activate one another and start this positive feedback effect. Many different things can cause you to be hypercoagulable. Number three, something like inflammation, as an example, might jumpstart this. So this is Virchow's triad. These are all examples of hypercoagulability, vascular damage, endothelial damage, and then things that might cause stasis. But we're going to go through this more in depth, so ignore these specifics. All right, so these are the ones that we're going to go through, and this is definitely good to know all of these. Starting with surgery. So if you have surgery, this kind of checks all three boxes on the Virchow's triad. Virchow's triad. One, you have surgery, so someone's cutting into you, so you should have inflammation. That is going to basically lower the threshold of activation of your coagulation system, so the factors might activate. Plus, I don't know why you're having surgery, but probably before, during, and after your surgery, you're probably not moving around as much. That's the stasis. And someone's cutting into you. That's endothelial damage, which is going to affect all this fun stuff that we just talked about over there. So this checks all three boxes, so you're much more likely to develop a clot after surgery. Trauma, so same thing. We get all three factors. So you get inflammation. Now, after the trauma, you're probably going to be immobile, and you have endothelial damage, breaking a bone or opening a wound. So in a vignette, you're looking for somebody who had a surgery a week ago, and then randomly they're having trouble breathing. Maybe that's a pulmonary embolism, or somebody got into a car accident yesterday, and maybe now they're a little dizzy, and that could be a stroke. So that's the way that you're going to try to interpret this in a question. Travel is a big one. They're going to say, someone was on a plane like 2 weeks ago or maybe a couple days ago, and now they have a pain in their leg. Well, that's a deep vein thrombosis. Malignancy, all three factors. They are, if you have cancer, you're probably not feeling great. So, maybe you're having chemo or surgery, so you're not moving during or after. The surgery can damage your endothelium. Chemotherapy, the tumor itself can damage the endothelium. Probably the biggest one, though, is that you're hypercoagulable because tumors are going to secrete various protein substances which are going to activate various coagulation factors. We don't need to know the specifics there, but just know that tumors release substances that activate coagulation factors. Next one. All right, pregnancy. So this probably evolved as a mechanism to prevent blood loss at delivery, and it works by two mechanisms. One, stasis of blood. There's less venous return due to the fetal obstruction, and so that causes the pooling, which makes clotting more likely. At the same time, you are hypercoagulable. The increased levels of estrogen are going to increase clotting factor production and decrease inhibitor production. Now, specifically, pregnant women are likely to get deep vein thrombosis, which may progress to a pulmonary embolism. So DVTs are actually very likely to progress to pulmonary embolisms, not just in pregnancy, but just period. But pregnant people, this is the more likely, is that it's DVT and or PE. Oral contraceptive pills, so on that last one, we just said that increasing estrogen. So, birth control is really often just a whole bunch of estrogen rolled up into a little pill. So this is going to increase coagulation factors and decrease the anticoagulation factors. Elevated homocysteine, this one's a little random. So causes endothelia injury, check. Activates the coagulation factors, check. Why might you have elevated homocysteine? So you guys cannot escape this ever. This graph is going to come back and haunt you for the rest of your life. Here's homocysteine, in the red. Now, to get this to methionine, I need B12. So if I have a B12 deficiency, this is going to go up. Now, to get it to methionine, yes, I need B12, but you also need folic acid to activate for the B12 to work off of. So if you have a folic acid folate deficiency, it's going to go up. On the other hand, homocysteine can be converted into cysteine. That needs vitamin B6. So if you have a B6 deficiency, or if you have a cystathione beta synthase, this enzyme deficiency, that also might cause it to go up. Nephrotic syndrome, you guys will learn more about this in the renal system, so I'll spare you. Basically, you have issues with your glomerulus, and you're going to lose proteins in the urine. One protein especially that you lose is antithrombin 3, and if you lose this, you're going to have excess coagulation. Smoking, I don't know if they really truly understand all of the mechanisms here, but fibrinogen levels increasing is a big one, so that's going to make you more coagulable. So now the inherited disorders. We're looking at these four. Factor 5, remember, is the wingman, the cofactor for factor 10 to activate prothrombin, which is factor 2 into thrombin. But it's called Leiden when it's mutated. So factor 5 is often inhibited by activated protein C. But basically, the mutated factor 5, called the Leiden factor, is just resistant to APC trying to turn it off, which means you're going to have extra coagulation. I think of like Leiden is in the Netherlands, and there's a bunch of Caucasian. So basically, this Leiden mutation is more likely in Caucasians over other ethnic groups. David Bloom in like 2003, I think he was a reporter for the Iraq War, and he just was kind of like a healthy, fit guy, and he died because he had maybe a pulmonary embolism or something. And it just brought a lot of awareness to this particular Leiden mutation and deep vein thrombosis. And he part of it was he was hypercoagulable because he had the Leiden mutation, but he's also sitting in a tank and in these tiny little armored vehicles for, hours and hours and hours every day. And so I think he left the tank at some point because his leg was cramping up just because it hurt so bad he needed to walk around. But then of course so he exposed himself to gunfire. That's how bad it hurt in his leg. And then he went back in, and then like a day later, the cramp in his leg was the deep vein thrombosis, and I went to his lungs, and he had a pulmonary embolism, and he died. But he's white, and the Netherlands are white, and so that's how I remember that the Leiden mutation is more likely to be found in Caucasians. So I would know it's a point mutation, and it causes an arginine to be converted into a glutamine, and again, that makes it resistant to degradation by APC, which teams up with protein S to inhibit it normally. A prothrombin mutation, you just got more of this. You got excess prothrombin, makes coagulation more likely. If you're heterozygous, meaning you've got one copy, you're going to have more. But if you're homozygous, you're going to have way more. So clotting is going to be an even larger issue. We've already talked about antithrombin 3, but let's just take another crack at it. So you might lose this because of a genetic inheritance, but it might also be nephrotic syndrome like we just talked about. So you're just peeing a lot of it out in the urine. How does antithrombin 3 work? It's activated by heparin sulfate, which is on healthy endothelial cells. That activates it. It then can inhibit factor 10 and factor 2. Heparin is going to look and work just like heparin sulfate. But if you have an antithrombin 3 deficiency, you just won't respond to heparin. So that's sometimes actually how it's diagnosed, is you're in the hospital and we're giving you heparin IV and it's just not doing anything. And then we find out, oh crap, you actually just don't have antithrombin 3. You have a much smaller amount of it. Protein C and protein S, so this inhibits 5 and 8. Again, notice a lot of this stuff is really easier if you just know the basic essentials for the coagulation cascade. So before you go ahead and learn these diseases and the hypercoagulable states and the bleeding states, just know how platelets work, know how coagulation factors work. It will be a much better investment for your time. So obviously, if you're deficient here, these are inhibitors of the system, you're going to have excess coagulation. So the important new bit of information here is that protein C. So warfarin, we know warfarin because it inhibits vitamin K. And we know, okay, vitamin K is necessary for coagulation factors. Yes, that's true, but there's a weird thing that there's also a prothrombotic effect to warfarin. Warfarin also inhibits protein C and protein S. And protein C, so if you inhibit vitamin K and vitamin K is necessary to activate protein C, that means you're inhibiting protein C. That may be a prothrombotic effect. Now, this is going to be especially the case if you have a protein C deficiency, because you're already low on protein C. You take warfarin. Protein C has a short half-life, so like factor 7, it's very quickly affected. You get tons of coagulation in the first couple of days. This presents as something called warfarin skin necrosis, which is quite ugly. This is warfarin skin necrosis. So for this reason, people are monitored, their PT and their INR when they're on warfarin for this specific reason. So again, you might have this to some extent, but the warfarin effect is going to be much more likely if someone's protein C deficient. Antiphospholipid syndrome, so people develop antibodies to phospholipids in their vasculature, common in people with lupus. And I would know that it's frequent miscarriages. If they talk about a woman who's had several miscarriages, think antiphospholipid syndrome. And that's because it causes a thrombosis in the uterine wall, so that the baby is basically starved of nutrients. A lot of antibodies, 3 different ones. So anticardiolipin, this is important it's a false positive for syphilis. The lupus anticoagulant. This will interfere with the intrinsic PTT test. This causes an elevation when it shouldn't be. And we can determine this through a mixing assay, which we'll talk about. So the other two can be determined through ELISA, but the lupus anticoagulant, more important, can be determined through a mixing assay. Know that anti-B2 glycoprotein is a thing, but there's no real superlatives about it. Diagnosing somebody with antiphospholipid syndrome, you need one of these 3 antibodies, but you also need a clinical symptom as well. So you either need a thrombosis or somebody who's just lost had a lot of miscarriages. So let's talk about the mixing study. This is kind of like the hemophilia factor 8 inhibitor that we talked about earlier. So the PTT, we take someone's plasma, we add calcium, we add an activator. What's an activator? It activates factor 12. Factor 12, if you recall, is activated by exposed collagen, which is negative. So we're looking for something with a negative charge, sometimes called contact factor. Silica has negative charge. All of this will just activate factor 12, which is going to activate the intrinsic pathway, which is the PTT. Now, the lupus anticoagulant, again, it's an antibody that is going to bind to phospholipids. It inhibits the phospholipids, so it is going to basically mess with this whole intrinsic pathway, which would elevate the PTT. But again, this is an artifact. This is it's just not giving us a real picture about how well the intrinsic pathway is actually working. So how can we determine if somebody, in fact, has one of these inhibitors? It's the same thing we saw with the hemophilia thing. A small amount of an inhibitor goes a long way. So if someone has antiphospholipid syndrome, they have the inhibitor, you mix them with normal serum, And now the inhibitor is still there. Just a little bit of inhibitor is going to do its job. It's going to prolong the PTT. And if you had something like hemophilia, where the issue is not an inhibitor, it's a deficiency of a coagulation factor, well, you really don't need that many clotting factors to have a normal PTT. So if you mix these two together, yeah, sure, you have a lot of less coagulation factors, but you don't really need that much, and there's no inhibitors, so the PTT would be normal. So this would be a way of differentiating an inhibitor of coagulation versus a deficiency of coagulation. So when might we go ahead and investigate whether or not somebody has, these antibodies or these genetic syndromes? If you have somebody who just randomly, they're young and they have a DVT or pulmonary embolism or a stroke or an MI for no good reason, you might go ahead and do some genetic tests on them for deficiencies in AT3 or protein CNS. The Leiden gene, which is resistant to degradation by activated protein C, heterozygous or homozygous for prothrombin, or the antibodies for phospholipids, also a cancer screening. Now this is controversial, maybe not for the cancer screening, but it's expensive, and a lot of these people are already on blood thinners, which just confounds it. Which, why do the test if we don't even have that much faith in the test? Also, what's the solution? We're just going to put you on a blood thinner for the rest of your life? I guess maybe, but that's not ideal either. So people debate whether or not the workup is actually worth it. All right, cool. Medications next.